Hi, today I'm going to discuss about female genital tract disorders, and starting with HPV-induced cervical intraepithelial dysplasia. So in this case, let's start with the normal histology. So here you see that's the cervix. This is the endocervix, which is closer to the cervix, and this is the ectocervix, which is closer to the outer region of the female genitalia. So it's important that here, this region is called the os of the cervix. So this is the transitional space where here you see there are columnar cells, and here we have squamous cells. So with the differentiation, the columnar cells differentiate into squamous cells, and here is the region where this differentiation happens. So HPV with this pathogenesis usually targets cells which are getting transitioned in here. So transitioned squamous cells are the main target of the HPV infection, which subsequently causes its effects in squamous cells near the os of the cervix, right? So let's just remember the pathophysiology of the HPV-induced cervical dysplasia. So HPV is a human papillomavirus which has a ability. It's a DNA-based virus. So when it infects the human cells, especially the cervical squamous cells, especially the serotypes, high-risk serotypes known as 16 and 18, have the ability to integrate into host cell DNA, right, in the genome. So when it gets integrated into the genome, there is loss of function of E2 protein, which is a negative regulator of E6 and E7 proteins. Those two proteins are the ones that are responsible for oncogenesis of this virus. So E6 suppresses the p53 gene, which is a tumor suppressor, and E7 suppresses RB gene, which is another tumor suppressor. So you see, if E2 usually regulates expression of those two proteins. So if E2 is active, no overexpression of E6 and E7 is happening, and consequently no dysplasia results afterwards, right? So in the case of integration in host genome, E2 loses its function, and E6 and E7 are getting overexpressed, which causes suppression of those tumor suppressor genes, consequently dysplasia, and afterwards cervical cancer, right? Of course, it's not that easy. There have to be other factors associated with it to progress into the cervical cancer, but that's the normal progression how it's happening, right? So now, what are the risk factors? So those are the high-risk serotypes, which causes most of the cervical cancer. Those are HPV 16 and 18. The risk factors associated with the HPV-induced cervical cancer are early age at first intercourse, as it can increase the risk of getting this sexually transmitted disease infection. The second risk factor is multiple sexual partners. The same problem here. Male partner with previous sexual partners, the same problem. Persistent infection by high-risk strains of papillomavirus. So there are other strains like HPV 6 and 11 that just cause regular warts on genital region, which are benign compared to ones that are malignant, HPV 16 and HPV 18. Okay, so pathological differentiation, the grading of this dysplasia is in two ways, right? The newer one is a two-way system. This is low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, right? We can differentiate them while looking at the pap smear, you see HPV-infected cells usually express coilocytosis, which is this kind of nuclei in this cell. So this is the normal cervical cell right here, right? And when it gets infected with the HPV, the abnormalities progress, like the nuclear size is getting bigger, the cell is getting darker, and etc. So it's visible in the Nobel diagnostic and the Nobel diagnostic and screening procedure called the pap smear. So you see coleocytes are getting the cervical cancer cells are getting more and more atypical. You see here, this is HPV infected, but it usually resembles the cervical cells, this one, but then it gets atypia when it progresses to the low squamous intraepithelial to high-grade squamous intraepithelial lesion. It gets more and more atypical, and then invasive cervical cancer is identical. The cells are identical to the ones with the high-grade squamous intraepithelial lesions. So during the pap smear, if a doctor recognizes the coilocyte and it looks like this, it's not very atypical from the regular cervical cell, they can make the diagnosis of low-grade squamous intraepithelial lesion. In this case, there is a mild dysplasia. It's not very severe. There's no treatment required, but it has to be very closely monitored. But in case of the high-grade squamous intraepithelial lesion, also known as cervical intraepithelial neoplasia 2, the doctor usually tries to monitor it much more closely, because there is increased risk of progression of this high-grade squamous intraepithelial lesion to the second more severe dysplasia, which will most likely progress to the invasive cervical cancer. So it's important to differentiate between low-grade squamous intraepithelial lesion with the high-grade squamous intraepithelial lesion, right? Okay, so this is cytologic examination, which is a pap smear, and pathologic examination is according to the second grading system, which is like cervical intraepithelial neoplasia 1, 2, and 3, depending on the atypia of the cervical cells. This is from the biopsy. You can see that there are atypical cells here with the nuclear cytoplasmic ratio very different from the normal cells. And then this is invasive cancer, right? Okay. So symptoms of invasive cervical cancer include vaginal bleeding. This is hemorrhage from the vagina. This is also pain. Dyspareunia, which is a painful pain during the sexual intercourse. There can be weight loss and inguinal lymphadenopathy. So those are classical symptoms of the invasive cervical cancer. Now the second topic, you can see in here as well, compared to the HPV infection here, which is like a new infection. There's nothing atypical here. There's viral DNA integration, which causes the dysplasia of the cervical cells. And here in invasive carcinoma, you can see that most of the cells are atypical in the cervix. Okay, the second disorder is going to be endometriosis, but before that, let's talk about adenomyosis. Endometriosis and adenomyosis both are the problems arising from the endometrium. In this case, you can see there's inappropriate migration or invasion of the structures by the endometrial tissue. So in the adenomyosis, you can see in the myometrium, the muscular layer of the uterus, you can see there are endometrial tissues here, right? Those are inappropriately aligned in the myometrium. Usually they have to be here, but somehow they differentiated and they migrated to the myometrium. So adenomyosis is always endometrial tissue, always confined in the myometrium. So the problem is here usually arises that the endometrium is getting symptoms same as endometriosis. Those are the pelvic pain, dysmenorrhagia, menorrhagia, dyspareunia, the painful sexual intercourse, and also the uterus is getting very enlarged. So this is adenomyosis when endometrial tissue is inside of the myometrium. Okay, so in case of the endometriosis, the endometrial tissue is not in the myometrium. It gets migrated in more distant sites. For example, it can be the fallopian tubes, endometrial tissue here. It can be the round ligament, I believe, here near the round ligament. It can be in the in between the uterus and the rectum, the retrovesical pouch. And also it can metastasize to a very distant site such as peritoneum or lungs, kidneys, or heart. But it's much less common. Usually it's near the uterus, somewhere in the fallopian tubes, ovaries, near the round ligament, or near this retrovesical pouch, right? So there are 4 hypotheses that none of them are proved. The most supported idea is the backflow theory, or something like this. That was believed that during the menstruation, due to menstrual backflow, the blood goes in the fallopian tubes and implantation happens. That's why they believe that endometriosis can be the cause of that, but none of the theories have been proved, so we don't know the exact basis of this disease. So let's talk about the symptoms of the endometriosis. So as I said, there are many locations where endometrial tissue can be aligned. So this endometrial tissue is not like a regular endometrial tissue. It has a much higher activity in terms of the pro-inflammatory mediators such as prostaglandins, which can lead to increased inflammation. So this endometrioid tissues can express prostaglandins, which can cause inflammation. And the second problem is that those endometrioid tissues, as they bleed regularly, they can wait, I forgot. Okay, wait just a second. PG2. Just this area. Okay, yes. So it also makes aromatase. It also contains an enzyme aromatase, which converts testosterone into estrogen, and it can lead to the increased levels of estrogen as well. So one of the treatment methods for the endometriosis, the management one, is the significance of usage of COX-2 inhibitors, such as NSAIDs, which will decrease the inflammatory processes due to the PGE2 expression from those endometrial tissues. And the second one is the aromatase inhibitors, which can be used in order to inhibit endometrioid tissue from creating more estrogen, right? So endometriosis symptoms. Now it's a chronic pelvic pain depending on where those endometrioid tissues are aligned. Consequently, those will cause symptoms that are associated with that location. For example, if it's in the rectovesical pouch, like near the rectum and the bladder, it is going to cause painful defecation, right? Because it is aligned near the rectum, so it will be painful for the person with this endometriosis to defecate. There's a dysmenorrhagia, menorrhagia, dyspareunia, which is painful intercourse. If those endometrioid tissues are near the cervix, that's when it happens. Painful defecation and diarrhea, constipation, dysuria. Rarely, this is when this endometrial tissue is near the bladder, right? Complications include infertility, iron deficiency anemia due to heavy bleeding, because usually the women with endometriosis experience more than 1 week bleeding series with heavy bleeding as well. So due to the blood loss, iron deficiency anemia can be caused. Endometrioid carcinoma of the ovary is also a complication of it. Physical signs, pelvic pain and cervical motion tenderness. And morphology includes on pathological examination, you can see chocolate cyst on the ovary. This is usually when the endometrioid tissue is near the ovary. The blood that is secreted from this endometrioid tissue is getting oxidized or something, and it has a characteristic brown blackish color, which is called a chocolate cyst. Black powder lesions on adnexa. Adnexa is the places like salpingus, the fallopian tubes, and near the round ligament. When the endometrioid tissues are there, it's like black powder lesions. It's like that kind of lesions. And abnormal metaplastic ectopic endometrial glands